Okay, so we'll move on to the next speaker, Divya RAO, AI monitoring based on handheld fundus camera images. So you're just moving on from ultra-wide camera to literally a handheld fundus camera. Divya.
Hello everyone, thank you so much for joining us today, and thank you to APO, AIOC, as well as the chairs Dr. Shobha and Dr. T.P. Das for giving an opportunity to speak today. And today I'll be focusing on AI-based screening using handheld fundus camera images. And here are my financial disclosures. Some of it is relevant to the talk that I'll be giving today. As Dr. Praveen has already alluded, diabetic retinopathy is going to rise. We are at 103 million today, and this is going to exponentially increase to 160 million by 2045. The Smart India study has shown that the prevalence of diabetic retinopathy is at 12.5%, with close to 3 to 4 million people aged over 40 years have VTDR, vision-threatening DR. And what is alarming is a significant proportion of these patients with diabetes were unaware of their status, and this cohort had a higher prevalence of diabetic retinopathy and VTDR. And this poses a significant economic burden on the individual and on the country, and also on the quality of life. However, a programmatic intervention of this can be successful, and the English National Diabetic Retinopathy Screening Program has shown that diabetic retinopathy is no longer the leading cause of blindness in the working age group, and over 80% of the people with diabetes who were offered screening completed the testing in 2019 and 20. So now we do have diabetic retinopathy screening guidelines in India as well, thanks to the consensus statement between the AIOS and VRSI. They've covered a lot of aspects in terms of screening models, annual screening for those with diabetes and more frequent for those with high risk, the type of fundus cameras to be used, minimum camera specifications, as well as stating that a single field image that includes the disc and macula should to be sufficient. Also covered things like targeted or stage mydriasis to improve gradability of images, and also made recommendations regarding teleophthalmology or use of AI software, and to maintain an NCD registry for these patients. There's also a recommendation to decentralize diabetic retinopathy screening to physicians who are the first point of contact of those with diabetes, and also made recommendations regarding teleophthalmology and AI-based screening for physicians as well, by also ensuring a care loop closure to the ophthalmologist to referral services. The utility of non-mydriatic fundus cameras and in diabetic retinopathy screening has also been alluded in these guidelines, and they have looked at handheld fundus cameras as well as smartphone-based fundus cameras. And the advantages being that these camera systems are universally accessible and can be affordable and cost-effective screening solutions, while acknowledging the limitations that some of these systems can definitely have reduced image quality in the elderly, especially with cataracts and small pupils. In India, Kerala has really taken a leap forward in diabetic retinopathy screening, thanks to the initial pilot that was done at the Nayanamritam project. This was done in collaboration with the Moorfields Eye Hospital as well as the government of Kerala, where they used smartphone-based imaging and teleophthalmic grading. And there was a clinical care pathway that was implemented as well for those detected with referable disease. And the outcomes of the project were that they saw 17% of those to be detected with diabetic retinopathy, 8% of those were referred, and alarmingly, 99% of them were unaware that they had diabetic retinopathy, and a majority of them were actually in the working age group. And they showed that this could be a cost-effective screening. Screening could be cost-effective because at 100 rupees, they were able to screen and treat patients when normalized across the population. And this allowed the screening to be expanded from 16 to 200 centers, and looking to add more centers this year. And now there's also reimbursement under ABDM-PMJY policy. So the key learnings were that diabetic retinopathy screening is cost-effective in India. And teleophthalmology-based screenings were not scalable as there were a lot of dependency on reading centers and training of graders. There was a need to pivot towards AI-based screening with immediacy of results, and the nurses could actually educate the patients on need for referral and further management, and this could potentially increase the uptake on treatment. And they also made a recommendation that a stage mydriasis was necessary to improve the gradability of images to at least 70%. Now, there are established global diabetic retinopathy screening programs that have included AI as part of their initiatives. Like in Scotland, AI has actually replaced the level 1 graders. In Thailand, they're using Google ADA, which is a cloud-based system. And in Singapore, they're also using the Selena, all of them showing that this can be promising and reducing the burden of diabetic retinopathy. In the US, there is the handheld camera system, which is also approved for use for diabetic retinopathy screening, along with AI showing good results. Now, what about in India? So through the Ornate project, they used a deep learning model for grading of diabetic retinopathy that was developed on mydriatic retinal images and applied it on non-mydriatic images in community settings. Though the results were not very promising, they had very key findings that offline AI was necessary without requiring internet or cloud infrastructure, and that referable DR recommendations, if through AI was possible while being trained on non-mydriatic images, could make it far more accurate. And immediacy of results was necessary, and deep learning models that can actually classify the gradability of images on these systems was essential for the end user. So in the Indian context, there is a smartphone-based fundus camera with integrated offline AI for diabetic retinopathy screening now that can expand the scope of diabetic retinopathy screening in India. And this system, you can do a stage mydriasis where first you can capture non-mydriatic images, and if the images are insufficient, then you can dilate as needed, and immediately it gives a feedback on the quality of the images, and with a click of a button, you can get a recommendation for referable diabetic retinopathy that is more than moderate severity, and this is nearly instantaneous, and you can also review these results remotely through teleophthalmology. This algorithm has been extensively validated in real-world settings against consensus grading of diabetic retinopathy through consensus grading for diabetic retinopathy through graders, and has received global regulatory approvals both in Europe and Singapore, and is also the first approved algorithm in India. So it's not about studies alone. This algorithm is also being implemented in real-world settings. In Kerala, now they've already adopted the system, and it's expanding from 50 to 210 centers. The Arvind Eye Care system, the SHOF system, has also adopted this, and through their hub and spoke models, the referral pathway has also been taken care of. And beyond India, it's been used in several settings like in Romania, the Dominican Republic, as well as several settings in Africa, in Zambia, and Tanzania as well. And this has allowed us to screen close to 500,000 people for retinal conditions over the past 1 year, and we've detected close to 48,000 cases of diabetic retinopathy. Now, this has moved beyond DR to referable glaucoma and referable AMD as well. And what we look at as future direction is that with this single retinal image, can you make screening more cost-effective by combining other disease conditions beyond diabetic retinopathy like glaucoma and AMD, and in the future systemic disease as well. And given the massive population that we have of diabetes, can we look at pre-screening methods with, say, point-of-care tests with cystatin that has shown promise, a lot of work that has been done by Dr. Shobha and Dr. Rajiv Raman? Can we look at predictive algorithms for personalized follow-up to extend the screening intervals in those with lower risk? And as also the previous speaker spoke, can we be looking in the future at portable SLO-based wide field imaging systems for smaller pupils in the elderly to reduce the amount of ungradability and pick up more diabetic retinopathy. So in summary, India is definitely moving forward. There are indigenously developed diabetic retinopathy algorithms, and the first approved in India is the one that we spoke about as well. This works completely on the edge, not requiring cloud inferencing, and is integrated within the camera system on the smartphone-based camera system with real-time gradability feedback. And there have been multiple prospective real-world clinical validations on this. Now we have established guidelines for screening for diabetic retinopathy. Though the adoption across states has been sparse, but with Kerala leading the way, we are on the right path. And with reimbursement models through the ABD and PMJY, this can boost the adoption rates. Thank you so much for your patience.